This conference will now be recorded.
All right, so it's been a long day teaching. I've been teaching lectures since 9 o'clock this morning. So if I start fading out, just kind of kick me back in. So let's talk about gastrointestinal and urologic emergencies. Get through these national competencies here. We talked about the introduction. Perfect. So obviously with abdominal pain, which is a very common complaint, we get dispatched for abdominal pains like you wouldn't believe. The question is what is causing that exact pain? Is it a diffuse? Is it acute? Things like that. So when we're dispatched to these types of calls, it's kind of a mystery on what's really going on because we can't see anything that we're doing. Really, it's based upon assessment, touching, feeling, palpating, auscultating, along with signs and symptoms that you may also have, like vital sign changes, and how the patient tells you they feel. And that's going to be a huge part of our abdominal assessment. So causes are often difficult. Like I said, they're difficult to identify because we can't see underneath the skin. We don't have the ability. I can't say we don't. Ultrasound is starting to come out into the field. More classes are being taught. They have the new one that hooks up to an iPad called the Butterfly. It's like about a $3,000 item, but things are starting to come out. But not a lot of paramedics are trained in ultrasound or even guided ultrasound with IVs or things like that. So again, it's going to be something new, a new tool for the trade to help us out. You do not need to determine the exact cause of acute abdominal pain, but can we reduce the pain to kind of help them out? Or is it something that's more life-threatening that we need to get them to a hospital in a more expeditious way? That's the biggest word I'm going to use all night. All right, so you need to be able to recognize a life-threatening problem and act swiftly in response, right? So we want to make sure we act swiftly in these responses because it could be an internal bleed. It could be an ectopic pregnancy. It could, obviously in the females only, right? So there's a lot of potentials that are there. So let's do more of an in-depth assessment. So the abdominal cavity contains solid and hollow organs that make up the GI, genital, and urinary systems. So the solid organs would be the liver, the spleen, the pancreas, the kidney, and the ovaries. So injury to a solid organ can cause shock and bleeding because it's solid, full of vessels. The vessels can bleed if there's an injury there, right? So we talked about like palpating the liver, how to assess that already. Looking at the pancreas, the kidneys being retroperitoneal, the ovaries being down in the lower part of the abdominal cavity, just in the area of the pelvis, right? And splenic injuries, having that referred pain to the shoulder. Okay, so we have a bunch of different things we can utilize based on palpation, touching, feeling, and looking at different signs and symptoms and referred pain to go back and forth. So here's kind of an idea of what the abdominal cavity contains. Okay, looking at our hollow organs, our solid organs, right? So the main function of the GI system, right, is to absorb the products of digestion to fuel the cells within the body. These consist of the mouth, the salivary glands, the pharynx, esophagus, stomach, intestines, liver, gallbladder, pancreas, rectum, and the anus, as you can see on the picture on the right-hand side. So all through here. Okay. The other part is your solid organs, like your liver, located here, your kidneys being retroperitoneal. So when we're assessing kidneys, we're pushing on the right and left side of the spinal cord in the back in the retroperitoneal cavity. So if we have a patient that has significant kidney stones, we put pressure. We're not going to press on their belly. We're going to do an abdominal assessment. We also want to make sure we're palpating on the backside as well, feeling that retroperitoneal area. Kidney stones, being as small in nature as they can be, can drop the biggest people to the ground, right? So we have our liver, which is located in the upper right-hand quadrant, underneath the rib cage, as I mentioned before. As you're palpating and take that deep breath in, you push it underneath. That's the tip of the liver I'm talking about that you actually be able to palpate, about 2 centimeters or so of the palpation. We have our pancreas located kind of in the middle, more towards the left upper quadrant, along with our spleen being in the left upper quadrant, and then our kidneys being retroperitoneal, ovaries being down below for females. So the entire digestion process takes between 8 to 72 hours. So salivary glands secrete saliva to help lubricate the food. So once swallowed, the food then moves down through the esophagus, which is pushed the food along using a rhythmic contractions called paracelsus. And the cardiac sphincter is designed to prevent food from backing up into the esophagus that's there, right? We don't have any kind of backup. The veins around the esophagus, in combination with others, form a portal vein as well. And this transports, the portal vein then transports venous blood from the GI tract directly to the liver for processing nutrients. So if blood flow through the liver slows, blood may back up throughout the entire GI system. If that happens, we potentially have the possibility of a gastrointestinal bleed. Okay, so we don't want any kind of backup through that system. Everything needs to be functioning appropriately. What are some things that could literally cause liver damage other than trauma?
Alcohol!
See, I gave you that segue, Tandra. Perfect. She is way too happy tonight.
My
She-
drunk ass will recognize that.
I was just gonna say she is way too hammered right now.
All right. What's something else that can also cause liver issues other than alcohol?
Hepatitis.
Hepatitis, right? Which one? A, B, C, D, E, F, G. Which one is it?
My brain's not working that well,
That's fair. Anybody else want to help her out? I got
but I'm
Justin.
thinking C.
Yeah, hepatitis C. You're gonna need some vitamin C for the morning, though. All right.
Why don't we mail her a banana bag?
I'm so glad I'm recording this. This is great. All right. So, on that note, the stomach. So this secretes hydrochloric acid to break down the food. Okay, so acid breaking stuff down. In turn, also absorbs water, alcohol, caffeine, and some medications as well. Right, our PO medications come down through. As it's absorbing, we always talk about, and we haven't covered more of this yet in medications, but the first pass effect. So the first pass effect is when our medicine gets into the liver and starts breaking stuff down, right? And that's how we start secreting that through our system in order to help treat, right? The liver secretes bile, filters out toxic substances, creates glucose stores, produces substances for blood clotting and immune function, and the gallbladder acts as a reservoir for all the bile that comes out of it, right? So we have a reservoir that takes all the bile from the liver. So as you can see, the liver is an important function of the body, which is why we want to make sure we don't destroy it. So if a patient is in liver failure, what would we most likely see for a symptom, or for a sign, I mean? What would we most likely see for a sign on a patient that has liver failure?
Yellow skin. Jaundice.
Yeah, jaundice. Exactly. But not necessarily just the skin. What part of the eyes would turn yellow?
Right.
The white part.
Sclera.
Yeah, the sclera. Perfect. All right. So let's talk about the intestines. All right, so the gastrointestinal system here. So the small intestines, duodenum, is the first part of the small intestine which absorbs resources for use by other cells in the body, where the pancreas, liver, and gallbladder connect to the digestive system, that same spot. The exocrine portion of the pancreas excretes enzymes into the duodenum that assist in digestion of fats, proteins, and carbohydrates. The pancreas also secretes the enzyme amylase, right, as well. So the pancreas also produces bicarbonate and insulin on top of that. So as you can see, the pancreas plays a huge part in sugar reduction. So the small intestines, where 90% of the absorption actually occurs, produces an enzyme that turns chyme into substances that can be absorbed by the capillaries of the small intestines. The jejunum is compromises a large amount of the surface area of the small intestines that does much of the work that's currently going on. The ileum is the final part of the small intestines, which absorbs nutrients that were not absorbed earlier, kind of takes up the rest of it, absorbs that bile acids, and absorbs vitamin B12. The large intestines, or the colon, is where substances not broken down enter the colon as a waste product or feces, right? So the primary role is to complete the reabsorption of water and solidify the digestive material. Now, if our colon, large intestines in our colon, is overosmotic, okay, hyperosmotic, what would happen there? Hyperosmotic. If a colon was hyperosmotic, what would happen? We talk about how it has to break down. The primary role is to reabsorption of water and solidify the digestive material to make it so it's a soft stool. But if you have an overosmotic colon and you're taking on too much water, anybody your thoughts? Diarrhea. Yep. All right. So the site of bacterial digestion as well, which helps finish the breakdown of the chyme and produces a gas as a byproduct. Right. So attached to the last portion of the colon is the rectum, and then the colon then terminates at the anus where the feces are expelled from the body. So really it all plays a part in a huge breakdown. Now, we talk about gastrointestinal assessment, right? What medications would cause this to cause backup, constipation? Continuous use of what type of medications can cause this? Yep, Justin's got it right. Opiates, narcotics. So you have a patient that has significant abdominal pain, right? And they utilize narcotics often for chronic pain. The potential is there to have that backup. So it's a good medical history to obtain as well. All right, so some additional abdominal organs. So the spleen has no digestive system function at all, but it is part of the lymphatic system, which assists in the filtration of blood. Also aids in the development of red blood cells and serves as a blood reservoir and produces antibodies to help the body fight off disease and infection. So our spleen is kind of important, right? It's also very, very vascular, right? So we have a splenic rupture, we can actually bleed quite a bit into the internal organs, right? It bleeds internally. Or then in that turn, you'll feel significant rigid abdomen, what they call ascites, and it'll be solid. Not like someone who has rock solid abs. I'm talking more solid than that, right? Very hard to touch, kind of distended a little bit. Right? This would be more indicative of internal bleeding. So the genital system for the male reproductive system, right? We have testicles, the epididymis, the vasa differentia, seminal vesicles, prostate gland, and the penis. As you can, we'll show you pictures next. Actually, the next pictures are the urinary system. Sorry about that. And then the female reproductive system: ovaries, fallopian tube, uterus, cervix, and the vagina. So, looking at the female reproductive system, if you have a female in childbearing years with unexplained abdominal pain, and they are currently sexually active, you would think what?
Ectopic pregnancy.
Exactly, ectopic pregnancy. And where would this ectopic pregnancy most likely be located, based on average? Yep, Perfect. Good job. The fallopian tube. All right. So the urinary system consists of the kidneys, right? The urinary bladder, the ureters, and the urethra. Okay. So looking at the picture we see here, opening through the penile opening down through here is the urethra. This is the reason why males or females get urinary tract infections. Most of the time, it's because, and why it's more susceptible in females, is because they have the shorter urethra, which allows infection to travel into the bladder or into the bladder faster, causing a significant infection or UTI. Right. Other things to consider as well for recurrent UTIs, even in males, are males that self-cath at home and don't use an aseptic technique, causing significant infection into the bladder itself. So as we place, as a Foley catheter is placed through the tip, right, the distal end of it goes into the bladder, and then a balloon is filled up with water. So that way there, it will still be able to drain, and it holds it from going through the urethra through the opening. Okay, that's the plan behind utilizing a Foley catheter. All right. Kidney infections can also happen as well, and there's really not a good breakdown of the kidney, but inside the kidney, there are multiple different nephrons, and inside the nephrons, there's different loops and the glomerulus that also sits inside there as well. They all take part in filtration of moving the fluids out of the kidneys, or let's just say filtering, and then providing urine to go into the bladder, which then turns into excretion, right? So inside of there, we have different ducts inside the kidney. So you have the ureter ducts through here. If we have a kidney stone, all right, the kidney stone is unable to pass through, getting into the ureters, okay, to start, therefore causing significant inflammation inside the kidney. So the best medication to give these patients, and it will be coming to an AEMT at some point in time in the very near future, is a medication called Toradol, or Ketorolac, another name for it. It's given intravenous. It can also be given intramuscular as well. And with that being said, it's given 15 milligrams. It's a high-powered NSAID to reduce inflammation. This inflammation is called renal colic, and renal colic can be treated with that. Right. So it's going to be an advanced EMT medication, I think, on the next protocol rollout for the New Hampshire Advance. So having an idea, retroperitoneal location. The bladder being located in the lower quadrant of the abdomen. So as we are palpating and feeling around, we can actually, tell if there's significant pain by palpating, looking for any kind of expression. And in the hospital, they have something called a bladder scanner, where they can actually take and they do like an image, not really, they do some of an image, and you get a reading of about how much fluid is in there based on palpation. It's actually a pretty interesting device. So there are two main functions of the urinary system. One is to regulate electrolytes, water content, and acids in the blood. And two, to remove metabolic waste, drug metabolites, and excess fluid. The kidneys also perform these functions continuously, filtering about 200 liters of blood per day. That's a lot of blood to be filtering through. So 200 liters a day on average. So here's kind of more of a breakdown. So this is actually a little bit better. So the kidneys produce hormones that generate new blood cells, red blood cells, and also help the liver convert glycogen into glucose. The nephrons, okay, and they don't really show it on here, but do you guys see where the arrow is pointing right now? The darker red spot? Those are nephrons, right? So nephrons, which are found in the cortex, okay, so the renal cortex in here, right, are the structural and functional units of the kidney that form that urine. Those are the ones that have the ascending and descending loops, the glomerulus as well, to help that filtration and produce that urine, right? So patients that are taking a medication, like a diuretic, Okay, so hydrochlorothiazide, furosemide, the water pill. What's happening is that inside these nephrons, there's an ascending loop that comes in there, not the descending, the ascending side. It helps stimulate that ascending loop that causes the patient to produce urine. Okay, it helps with that diuretic. That's why they call Lasix a loop diuretic to help produce urine. The problem with Lasix is a non-potassium sparing. So what's happening is that the patient is pissing out their potassium and unable to replenish that back into the system. Right? Patients that have low potassium levels or hypokalemia, right, will start developing cardiac symptoms like cardiac arrhythmias that we talked about in last class, right? So there's a lot behind this, the roles that these things play. So these play a major role in maintaining homeostasis, right? They play a major role. If we can't filter, our body is on an even playing ground. And in turn, we're unable to regulate our electrolytes. It also helps eliminate metabolic waste products from the blood. So when the kidneys fail, the patient loses the ability to excrete urea from the body, leading to a collection called uremia, or condition. So once the urine enters the collecting ducts, it passes through the major calyx, or the minor calyx into the major calyx, and then into the renal pelvis. The urine then moves through the ureters and is stored in the urinary bladder. The brain then exerts control over the urge to void. Then urine is expelled from the bladder through the urethra and out into the open air, out into the open world. So a little bit about pathophysiology. So acute abdomen refers to the sudden onset of abdominal pain that indicates an irritation of the peritoneum or peritonitis. Anything that ends in itis, itis means inflammation, right? So if I said pericarditis, inflammation of the pericardium, things like that. Appendicitis, inflammation of the appendix, right? Anything that ends in itis would be an inflammation. So peritonitis can be caused by infection, a penetrating abdominal wound, a blunt injury severe enough to damage abdominal organs, or many other diseases that are there. So severe pain in peritonitis is usually the major symptom. So clinical signs are abdominal tenderness and distension. These patients that have peritonitis or significant pain like this truly require pain management, right? Now, at the advanced EMT level for pain management, you do carry nitrous oxide, but that is only for orthopedic injuries only. We want to make sure that we stay far away from anything with a gas as an introduction to pain management in the abdominal cavity. Because if there is an issue with the abdomen, we do have a bleed of some sort, or there's an organ that is open, we don't want to put free air into our abdominal cavity. All right. So the peritoneum consists of two membranes: the parietal peritoneum, which lines the walls of the abdominal cavity. That's supplied by the same nerves from the spinal cord that supplies the skin overlying the abdomen. This can perceive the sensations of pain, touch, pressure, heat, and cold. The visceral peritoneum covers the surface of each of the organs in the abdominal cavity. So these are supplied by the autonomic nervous system. When stimulated, when distension or contraction of the hollow organs activates a stretch receptor. This sensation is usually interpreted as colic or a severe intermittent cramping pain. So when receptors at the affected organs are stimulated, they send impulses along the nerves to the brain, where the impulses are then evaluated and interpreted as pain. So visceral pain is a type of pain that is commonly associated with urologic emergent problems. So it usually occurs when receptors in the hollow structures, such as the ureters, urinary bladder, urethra, are stimulated. And pinpointing the source of such pain is challenging because only a few nerve fibers may be involved in the entire pain transmission. So it'll be hard to find, kind of pinpoint exactly where it's located. Referred pain, or painful sensations that occur because of an irritated visceral peritoneum, may be perceived as a distant point of the surface of the body, such as the back or shoulder. All right. So as you can see in the picture here, with resultant connection between the body's two separate nervous systems. So patients that have gallbladder located here, right, gallbladder pain, we have our synapse points, which are located here and here. So if you have pain here, it refers up to the right shoulder, right, with the gallbladder as well. It's what we call referred pain, because the pain then travels up those nerves through the synapse points, causing increased pain somewhere else in the body. Remember that our body is full of dermatomes. The dermatomes help with sensation based upon your spinal cord and the area it's located in. If I have a picture, I'll show it to you guys later on. All right, so peritonitis typically causes the ileus, vomiting, associated with loss of fluid into the abdominal cavity, potentially causing hypovolemic shock, peritonitis, right? Patient might go into hypovolemic shock due to increased fluid disposal. So the patient may have normal vital signs or signs of shock. Fever may or may not be present for this. It may be seen in patients with diverticulitis or cholecystitis as well. Patients with acute appendicitis may have normal temperatures until the appendix ruptures and the abscess starts to form. When that happens, now remember, when the appendix ruptures, all that disease or mucus, or I should say pus, whatever is inside the appendix, that causes that significant inflammation, is now leaking throughout the entire peritoneal cavity. So diseases and conditions of the renal and urologic systems range from urinary tract infections to an acute kidney injury. Okay. The way to tell with kidney injuries and infiltration is going to be done through a complete metabolic panel where they do liver or LFTs called liver testing, and they're also going to look at what they call BUN and creatinine. That measures kidney function as well, which we kind of covered a little bit in our lab stuff that we did throughout the class, but nothing too in detail. But many conditions may also cause urinary retention as well. All right. So as you can see here, looking for locations of pain, and you can look at table 20.1 on the screen. This shows common abdominal conditions, right, where appendix would be located. So the appendix is located on the right lower quadrant, right? And we'll be able to locate this through what they call McBurney's point, which we talked about in depth multiple times. Cholecystitis, right shoulder, referred pain, right upper quadrant, direct. You guys can read right down through from all the way down to peritonitis, hernia, pneumonia as well. Kidney stones, right and left flank. Those would be more of your renal colic. So any other causes, some other causes of acute abdominal injuries, or I should say pain, or any condition that allows pus, blood, feces, urine, gastric juice, intestinal contents, bile, pancreatic juice, amniotic fluid, or any other foreign material to accumulate within the or adjacent to the abdominal cavity can cause peritonitis and acute abdomen issues. This stuff is not supposed to be out into the open cavity. That's why it causes that inflammation. Retroperitoneal organs can also result in acute abdominal pain as well, so are our kidneys. And almost every kind of abdominal problem can be acute, can cause acute abdominal issues as well. So as far as gastrointestinal hemorrhage goes, bleeding within the GI tract is a symptom of a disease, not the disease itself. It's a symptom of what's going on. This can be acute and or chronic. So all complaints of bleeding should be considered serious. Okay, if you have a rectal bleed or a GI bleed, upper or lower, it's considered a serious issue because we're bleeding outside of our cavities where blood is supposed to be kept. This can occur in the upper or lower GI tract, upper GI tract vomiting, blood, lower GI tract pooping blood. So in the esophagus, bleeding conditions might stem from what they call esophagitis, so inflammation of the esophagus, esophageal varices, or Mallory-Weiss tear. Hematemesis, or vomiting blood, is frequently seen in patients with upper GI bleeds. An upper GI bleed may also manifest as melena, or dark tarry stools, as a result of a partial digestion of the blood. The common causes of bleeding in the lower GI tract would include bowel inflammation, diverticulitis, diverticulosis, cancer, and hemorrhoids. So in a lower GI tract bleeding, the blood is often bright red unless it is coming from higher up in the digestive tract. Esophagitis is an inflammation of the esophagus caused by an infectious process or by reflux of gastric secretions into the esophagus. This can be caused by medications, chemotherapy, or radiation therapy, and associated with eosinophils. Excuse me. All right. So effects are irritation and swelling. So patients will present with either heartburn, choking, as their primary complaints. So most commonly occurs in patients with a gastroesophageal reflux disease, or GERD. So we've been doing this job for a while, most of us in the group. Okay. What medication would you most likely see a patient on if they have GERD?
Zantac, Protonix,
Yeah.
Prilosec,
Yeah.
Pepsid.
Omeprazole.
And
Pepsid.
Toprazole.
Yeah. Pantoprazole.
There's tons of them out there.
There are. So if a patient says, I really don't know my history, my doctor says take these medications, right? Those are the ones we're looking at the medication list. If we see these medications, we understand that this patient has GERD or gastric reflux, right? So they're complaining of a burning sensation in their chest. Well, could it be an acid reflux issue? Maybe. Don't rule out MI, but still keep it in the back of your head. They're on all these medications for acid reflux or GERD, all right? So just keep a note of that stuff. So more about GERD. So the GERD is caused by a sphincter between the esophagus and the stomach, and the stomach opens, allowing stomach acid to move superiorly. Also referred to as acid reflux disease, where you get that heartburn, that sensation, that burning sensation within the chest. Smoking, obesity, and pregnancy increase the chances of GERD. So eating fatty fried foods, drinking alcohol, and eating citrus fruits are also factors that are associated with GERD as well. So if the reflux continues over a long period of time, damage can occur to that esophageal wall. Remember, the esophageal wall, being a smooth muscle, cannot handle that high content of acidity. Right, so this could result in a weakened portion that are more susceptible to bleeding. So heartburn is the predominant clinical finding for this condition. Right, so pain may be increased with positional changes. Also, some patients may also experience coughing or having some difficulty swallowing, and bleeding can occur if the damage is long-term, resulting in a either vomiting blood, whether it be a bright blood or a melena type, dark type blood. So peptic ulcer disease and gastritis is when the stomach and the duodenum are susceptible to high levels of acidity. So high levels of acidity also can result in ulcers. So why is that important to understand if they have currently active bleeding ulcers? Yeah, Justin putting down aspirin administration, right? So aspirin administration can is a contraindication with actively bleeding ulcers. We also have peptic ulcer disease, or the protective layer erodes, allowing acids to eat through the organs. Gastritis, which is caused by the same imbalance between stomach acid and the protective layers. Pre-ulcerative state is when the stomach is inflamed, but erosion has not yet occurred. So peptic ulcers are usually the result of the Helicobacter pylori, erosive gastritis, resulting from chronic use of NSAIDs, non-steroidal anti-inflammatory drugs, alcohol, and smoking. So PUD affects men and women equally, but occurs more frequently in older age groups. So the foodborne infections and food allergies also can cause inflammation as well, right? So uncooked food can cause inflammation, or raw food, food that has been sitting out too long in the open air, not meeting their appropriate temperatures. So patients experience a burning and gnawing pain in the stomach for this. It subsides or diminishes after eating, and then also reemerges 2 to 3 hours later, usually present in the upper abdomen, whether we write about the upper quadrant. Nausea, vomiting, belching, and heartburn are very common with this. Again, hematemesis or melena can also occur if erosion is definitely severe. Some ulcers heal without intervention. Some require intervention. So complications can often occur from bleeding or perforation as well. Right, so it's good to ask the question, do you have any bleeding ulcers? The Mallory-Wise tear is a tear in the junction between the esophagus and the stomach, causing severe bleeding and potentially death. So primary risk factors would be alcoholism or eating disorders. Mallory-Wise tears have a sudden onset and affect people of any age. So violent coughing and vomiting are principal causes of this. In women, it may be associated with severe vomiting related to pregnancy, or the extent of bleeding can also range from being minor to severe. In extreme cases, patients may also experience signs and symptoms of shock, upper abdominal pain, and the vomiting of blood. So Bordeaux syndrome occurs during vomiting, similar to a Mallory-Wise tear, where the esophagus tears longitudinally, and the tear travels entirely through the wall of the esophagus. This creates a passage for blood, air, and food out of the esophagus into the mediastinum. This occurs more often in men. It presents after a large meal that included alcohol consumption. So esophageal varices. Has anybody ever dealt with an esophageal varices before? Actually rupture? No? I've had a couple cases where this has happened. 80% of the time I've actually had this happen. I can tell you about 80%. Usually the patient's dead. So to kind of put it in perspective, it's hemorrhoids in the esophagus, usually caused by excessive alcohol intake, not alcohol intake, but alcoholics. So this occurs when the amount of pressure within the blood vessels surrounding the esophagus increases. So then at that point in time, blood is blocked in the portal vessels dilating, causing capillary network of the esophagus to begin leaking. So now it's leaking blood. If the pressure continues to build, the vessel walls may fail, causing a massive upper GI bleed, right? Upper GI bleeding and vomiting of blood. So in the industrialized countries, alcohol is the main cause of portal hypertension. So in developing countries, viral hepatitis is the main cause of liver damage. So the presentation takes two forms. Initially, the patient shows signs of liver disease, fatigue, weight loss, jaundice, anorexia, edema, abdominal pain, nausea, vomiting. Then gradually the disease process starts to move forward, which can take months to years before the patient feels extreme discomfort. The second presentation is the rupture of varices, okay, which is more sudden. So sudden onset of discomfort in the epigastric region or sternum. So this is severe difficulty swallowing, vomiting of bright red blood, hypotension, signs of shock, hematemesis and melena are very likely. And then drainage to these vessels can also be very life-threatening. All right, how are we doing so far? Good? Perfect, all right. So as we can see, going through the presentation so far, abdominal pain is like a mystery, right? Not being able to have the ability to see it, right, makes things a lot more difficult. And we can tell if someone has a cut arm. We can tell if someone's having chest pain. We can focus on it. We can test it. There's nothing we're going to do for testing other than palpation for a patient with severe abdominal pain or abdominal pain that's unexplained. Right, so hemorrhoids, which creates a swelling and inflammation of the blood vessels surrounding the rectum. It's a very common problem, more than people even realize. 1/2 of the population has had at least one by age 50. This may result in conditions that increase pressure on the rectum or irritation of the rectum. May be caused by pregnancy, straining a stool, and chronic constipation. Diarrhea can also cause inflammation. So presence of bright red blood during defecation may also be present. So minimal bleeding and easy to control. Patients may also experience itching and a small mass on the rectum as well. For non-hemorrhagic conditions, the gallstones can form and block the outlet from the gallbladder, causing significant pain. So if the blockage does not pass, excuse me, it can lead to inflammation of the gallbladder called cholecystitis. So the gallbladder can rupture in severe cases. Presents as a constant severe pain in the right upper mid-abdominal region. It may refer to the right upper back, shoulder area, or flank. Pain may be steadily increased for hours, or they may just come and go. Symptoms commonly appear about 30 minutes after a particularly fatty meal, is usually at night. So some symptoms would be general GI distress, nausea, vomiting, indigestion, bloating, gas, and belching. All right. So pancreatitis is caused by an obstructing gallstone, alcohol abuse, or other diseases. Some signs and symptoms would be severe pain in the upper left and right upper quadrants, often radiating to the back. Nausea, vomiting, abdominal tenderness, distension, and sepsis or hemorrhage may also occur. All right, so appendicitis, frequent cause of acute abdominal pain, which can cause an abscess, peritonitis, or shock. The pain is usually more generalized, dull, and diffuse, which may center an umbilical area. Pain later localized to the right lower quadrant may also cause referred pain. All right. So some signs and symptoms, obviously, with nausea, vomiting, anorexia, or lack of appetite for food, fever, chills, rebound tenderness. So if you press down on the belly and it comes back up, rebound tenderness there. Or women who are pregnant may also not exhibit any of this. So you got to kind of pay attention to that for the appendicitis. So one of the more common ones that we come in contact with is gastroenteritis. So with this is a family of conditions revolving around a central theme of infection, usually caused by bacterial or viral organisms, which typically via contaminated food or water. Patients may begin to experience an upset stomach and diarrhea as soon as several hours or several days after contact with a contaminated matter. This disease can run its course in 2 to 3 days or continue for several weeks. May also have been caused by non-infectious conditions such as adverse reactions to medications, exposure to certain toxins or chemotherapy as well. Some symptoms would be large dumping type of diarrhea and frequently small, liquid stools, diarrhea containing blood and or pus may have foul odors or could be odorless, abdominal cramping, nausea, vomiting, fever, anorexia, and dehydration. If any of you had, I'm sure everybody here has had gastroenteritis at one point in time in their life, right? It's not fun. It goes away. What to look for would be more of the dehydration, especially with excessive vomiting. All right. So diverticulitis was first recognized around 1900 when the types of foods people ate started to change dramatically. As amount of fiber consumed decreases, consistency of the stools became more solid, requiring more intestinal contractions, increasing pressure in the colon as well. So this is other things for this would be like bulges in the colonic walls, resulting from increased intestinal contractions, to evenly turn into pouches called diverticula. Okay, so fecal matter is then caught in bulges. Okay, we talked about the pouches that are there, and then bacteria starts to form, causing localized inflammation and infection. The main symptom is abdominal pain, usually on the left side if it's the lower abdomen. And classic signs would include fever, malaise, body aches, chills, nausea, vomiting. Bleeding is very rare, and adhesions may also develop, narrowing the diameter of the colon, and results in constipation and bowel obstruction. In severe cases, these infected outcroppings may burst, causing a perforation of the affected segment of the colon. Some other chronic inflammatory conditions would be ulcerative colitis, which is caused by inflammation of the colon. Inflammation is usually generalized, affecting the inner lining of the intestines. Right, so causes of inflammation are very unclear with this, but genetic stress, autoimmunity have been speculated to be responsible for this. Inflammation causes a thinning of the intestinal walls, resulting in a weakened, dilated rectum. So in the United States, approximately 1 million people have had ulcerative colitis. So this occurs more often in men than women. Strong family history component. Signs and symptoms would be a gradual onset of bloody diarrhea, mid to severe abdominal pain, joint pain and skin lesions, fever, fatigue, and a loss of appetite. All right. Irritable bowel syndrome. So patients have abdominal pain and changes in their bowel habits. One diagnostic criteria is that the patients have pain at least 3 days per month for at least 3 months. The pathology of the disease is very unclear. However, there are 3 main factors observed in patients with IBS. One is a hypersensitivity to bowel pain receptors. 2, hyperresponsiveness of the stomach or the smooth muscles in the bowel, or a psychiatric disorder's connection to IBS. So problems with the bowel habits typically begin during childhood, where they can be triggered by stress, large meals, certain foods, as well as wheat, rye, chocolate, almond, milk products, and caffeinated drinks. A chronic condition may present with abdominal pain or discomfort, relieved by usually relieved by a bowel movement. And then patients may also experience diarrhea and constipation, or may feel bloated. All right, going over some more diseases here. So Crohn's disease is a similar ulcerative colitis, but can involve the entire GI tract from the mouth to the anus. The part of the GI tract to be affected is the ileum as well. So there's no definitive causes that have really been identified for this, and it affects hundreds of thousands of Americans. Most patients between ages 15 to 35. The incidence among older adults between ages 60 and 70 have also been identified. It affects more whites than African Americans, and people of Jewish descent have a notably increased incident with this. All right, so presence of signs and symptoms outside the GI tract, as well as family history and genetics, also play a role. So it's good to get that deep down, in-depth assessment for these patients to find out if they're if they have any history of Crohn's disease. So truly talk to your patients. The patients present with a chronic complaint of abdominal pain, often in the lower right area. So rectal bleeding, weight loss, diarrhea, arthritis, skin problems, and fever may also be present for Crohn's disease. So other conditions range from urinary tract infections to acute kidney injuries. The pre-hospital care is usually supportive for this. There isn't much we're really going to do. Unless we have a patient like with a kidney stone, we can treat that with some pain management. All right. So the bladder or the UTIs or bladder inflammation, or what they call cystitis, which usually develops in the lower urinary tract, urethra or bladder, when bacteria enters urethra and start to grow. This is more common in women due to the fact they have a shorter urethra. And UTIs are in the upper urinary tract, or ureters or kidneys, most often when a lower UTI goes untreated. So it tends to travel up that tract into the kidneys, right? So we want to make sure that we recognize urosepsis or even a UTI before it hits septic patient and get them treated with antibiotics. In severe cases, like I said, this could lead to sepsis. That's the urosepsis part. Common symptoms of the lower UTI: painful urination, frequent urges to urinate, difficulty in urination. The pain usually begins as a visceral discomfort, which becomes extreme burning pain, especially during urination. It also remains localized in the pelvis and perceived as a bladder pain in women and as a prostate pain in men. Sometimes the pain is referred to the shoulder or neck as well, and urine may also have a foul odor, and it may appear cloudy. So when you have a patient with a Foley catheter bag in place, check it out. Take a look at it. See if it's cloudy, full of what color it may be, if it's cloudy or not. Is there any blood in it? Look at that. All right, so we've been at this for an hour. We started at 6. Let's take 10 minutes. We'll come back and we'll continue on. So see you guys back here at 7:08.
This conference will now be recorded.
All right, so kidney stones, pathophysiology of the renal system. So we deal a lot with kidney stones. Patients that usually get them usually have recurrent kidney stones, right? So one of the things we got to pay attention to is the fact that this can cause significant pain, sharp pain, whether it be right or left kidney, if they're that unlucky to get bilateral stones, right? But usually it's one or the other side. With that, the crystallized uric, the salts, like they talk about here, they arise when the excess insoluble salts and uric acid crystallizes in the urine, causing like a calcium deposit. That calcium deposit then starts rubbing against the, my goodness, I'm having a moment, the tubes, causing significant inflammation because it doesn't pass through, right? So it has to break itself up internally to be able to pass through when they pass the stone, which is significantly painful. It can also cause, I'm not gonna say tearing, but like abrasions within the ureter and the urethra coming out, causing blood in the urine, right? So these things either pass on their own or they go in and they break them up through surgical intervention, right? So with that being said, we got to find a way to reduce that inflammation. So we talked about that already. Toradol is one of the best medications you can ever give, above and beyond giving narcotics, to reduce inflammation and reduce that pain in the kidneys. So that's how that works in that point. So calcium stones, or the calcium divided stones, are most common and occur more frequently in men. It may have a hereditary component. People that have had this in the past in family tend to get them more often. Increased soda, coffee, the things like that, the soda drinkers and all that can also cause potential for stones as well. These also occur in patients with metabolic disorders such as gout or hormonal disorders as well. So people with kidney stones are almost always in severe pain, right? So the pain usually starts as a vague discomfort in the flank, but becomes very intense within 30 to 60 minutes. Then it comes in waves. It also it may migrate forward toward the groin as the stone passes through the system. Right, so significant groin pain, kidney pain, retroperitoneal, increasing pain on palpation on the assessment. So some patients may also be agitated and restless as they walk and move in the attempt to relieve the pain. The pain can be so strong, literally it can drop a guy down to the ground. Right, small little millimeter stone. So others will attempt to remain motionless and guard that abdomen as well. Vital signs are really very depending on the severity of the pain itself. If the stone has become dislodged or in the lower part of the ureter, signs and symptoms of a UTI may be present, but the patient will not have a fever. Kidney stones may be categorized as either acute or chronic. In the United States, the prevalence of the chronic kidney disease is approximately 14%. The two leading causes of kidney diseases are high blood pressure and uncontrolled diabetes. AKI, or acute kidney injury, is a sudden decrease in kidney function with increase in toxins in the blood. They're often reversible if promptly diagnosed and treated. However, oliguria, urine output less than 500 mLs per day. Anuria is a cessation of urine production completely, so no urine at all. The patient may also experience generalized edema, acid buildup, and high levels of waste products in the blood. And if left untreated, can lead to heart failure, hypertension, and metabolic acidosis. Chronic kidney disease is progressive and irreversible inadequate kidney function, resulting from permanent loss of the nephrons. So our nephrons have failed. This develops over months or years and often caused by a systemic disease such as diabetes or hypertension. That's why patients that are diabetics have to routinely get labs drawn to make sure that their kidneys are functioning appropriately. However, early recognition and appropriate dieting and keeping your A1C low enough and everything else, you have a less of a chance of having inadequate or acute or chronic kidney disease. Could also be caused by congenital disorders or prolonged pyelonephritis, or it can also be the secondary effect of some infections, including strep throat as well. So scarring occurs as the nephrons of the kidney become damaged and cease to function, where that nephron is there to help produce and filter out the fluids. Waste products and fluid then build up in the blood, and then you get systemic complications like hypertension, heart failure, anemia, and electrolyte imbalances. As far as some signs and symptoms, altered level of consciousness, seizures, pale, cool, moist skin, jaundice, edema, muscle twitching, hypotension, tachycardia, pericarditis, pulmonary edema, uremic frost, signs of anemia, cramps, headaches, nausea, lethargy, all these different things. The uremic frost, by the way, is an accumulation of uric acid, especially on the face as well. So health excuse me, health expenditures for patients with chronic kidney disease are notoriously high with this as well. So end-stage renal disease are kidneys that have lost most of their ability to function, or toxic waste materials build up in the blood. This is fatal unless treated by dialysis or renal transplantation, so kidney transplants. Or they go to dialysis, they'll either get at home dialysis or they'll get dialysis done in a facility, and usually it's 3 times a week in doing this. So signs and symptoms are the initial signs of confusion, shortness of breath, peripheral edema, bruising, chest pain, and bone pain. As toxins accumulate, pruritus, nausea and vomiting, muscle twitching and tremors and hallucinations may start to occur. Lethargy, headaches, cramps, and signs of anemia as well, with pale, cool, and moist skin, where the skin may appear to be jaundiced or bruised. Uremic frost may also be present around the face. Edema of the extremities and face are very apparent. Patients are hypotensive and tachycardic, and pericarditis and pulmonary edema are also very common. In the late stages, seizure and comas are definitely possible. One of the indicators of pericarditis, other than the chest pain, is if you did a 12 lead, you'd show ST elevation. The ST segment would be elevated in every lead. I've had a couple patients with this that I've seen over time doing a 12 lead in the field and saw ST elevation all over, like a global MI. But it was pericarditis. All right. As far as gynecologic or problems, they're a very common cause of acute abdominal pain. We're going to cover more of the gynecologic stuff here in a second. Always consider that a woman with lower quadrant abdominal pain and tenderness may have a problem related to her ovaries, fallopian tube, or uterus. And pain may be related to the release of an egg from an ovary as part of the normal menstrual cycle. Most common place, fallopian tube. Pelvic inflammatory disease is an infection of the fallopian tubes and surrounding tissue of the pelvis, right? A lot of times you'll get this through sexually transmitted diseases. Symptoms are intense pain in the lower abdomen and high fever. This can be very fatal if not treated. The ectopic pregnancy, so 1 to 2% of all pregnancies are ectopic. A fertilized egg then implants outside the uterus, usually in the fallopian tube. That's the most common place. The fallopian tube can only support growth of a fetus or in a placenta for about 6 to 8 weeks. After that, a rupture can produce massive internal hemorrhaging and acute abdominal pain, generally on one side. The acute abdomen may also be associated with an onset of hypovolemic shock, right? Unexplained abdominal pain, shock-like symptoms, shock-like vital signs. They've been sexually active, right? Should be an ectopic pregnancy. Don't ever rule it, just don't rule it out. Epididymitis and orchitis are a complication of a UTI. Excuse me, an infection that causes inflammation of the epididymis along with the posterior border of the testes. With arthritis, the infection causes one or both testes to become enlarged and tender, leading to pain and swelling of the scrotum. Right? There are other issues as well, which we'll get into with torsion and things like that. Swelling may also occur in the groin on the affected side. So pain may increase during bowel movements, and the patient will have a fever, and the urine will have a foul odor. Pre-hospital management of these conditions is just supportive care. Get them to the hospital. So priapism is a painful, tender, persistent erection. It can result from diseases such as leukemia and tumors, blunt perennial trauma, spinal cord injury, the use of cocaine and certain prescription medications or drugs for erectile dysfunction. And maintain the patient's privacy. Do not make assumptions about the cause of the condition. I've also seen this with Seroquel before too. Patients that have gotten erections from that they could not relieve. There's nothing we're going to do in the field. They need to be lanced when they get to the hospital. Please do not start sticking catheters down there. It's not our job. So BPH, benign prostate hypertrophy, is an age-related, non-malignant enlargement of the prostate gland, which occurs in approximately 50% of men older than 60 years old. This may be asymptomatic or may lead to difficulty starting urine flow, slow, weak urine flow once started, incomplete emptying of the bladder, increased urination at night, and urinary retention. A lot of times if they have this kind of retention, they'll be getting capped. They'll be doing a self-cast at home. Testicular masses are rarely require pre-hospital treatment, may be painful or painless. If painful, the pain may radiate up the spermatic cord or may be localized to the specific scrotal point. Most are benign cyst masses or varicoreal or painless masses or dilated veins posterior to the testicle. Testicular cancer usually presents as a painless solid lump on the testicle itself. Testicular torsion is a twisting of the testicles on the spermatic cord from which it is suspended. So it starts to twist. This is a true emergency, and they need to have urology to take care of this. Associated with sudden onset of scrotal pain and swelling, or a surgical emergency because the twisting of the vessels reduces blood flow to the testes. So especially someone who's a younger age, or this can be very detrimental because it can actually cause to the point where they can no longer potentially reproduce and have kids. Torsion is usually unilateral, occurring only on one testis at a time, or testis at a time. So torsions may also occur with or without blunt trauma, as well a testicular lump or a blood in the semen. I've seen torsion happen with younger males that have been riding bicycles, and they just happen to sit down wrong on the seat as they're biking, and somehow they twist, causing that blood flow to be restricted. In older people, other organ systems, older people, the wall of the aorta sometimes develops weak areas that swell to form an aneurysm. So the development of an aneurysm, unless actively dissecting, is rarely associated with any symptoms. If an aneurysm tears or ruptures, massive hemorrhage may occur with signs of acute peritoneal irritation and hemorrhagic shock. Patients may also report to have severe pain in the back. Bleeding usually leads to profound shock, so quick shock, especially of an aortic tear. Things you want to look for these is palpate around the umbilical area, the belly button, and you want to look for palpable or pulsating masses. Now, if everybody right now in the class were to take their fingers, push on their belly button, you're going to feel a pulse. That's okay. That's your aorta. It's that strong pulsating mass that you feel, right, versus just the aorta itself. Those are the ones we need to be concerned about. For a hernia is a protrusion of an organ or tissue through a hole or opening in the body cavity where it does not belong. This can occur as a result of congenital defect, as around the umbilicus, surgical wounds that have failed to heal properly, a natural weakness in the area, such as the groin as well. They do not always produce a mass or a lump, but if you feel one, we do not put those back in place, okay? That's what physicians do. We do not push them back into place. Extreme obesity may also interfere with the ability to identify the mass that's actually there. So reducible hernias pose little risk and can be pushed back into the body cavity. All right, we are not doing that. If the mass cannot be pushed back in within the body, it's said to be incarcerated. With that being said, these are more surgical interventions, nothing that we're going to be doing in the field. So an incarcerated hernia may become seriously compressed by surrounding tissue, eventually compromising blood supply. All right, this is the strangulation. So the situation is called strangulation and is a serious medical emergency where they need immediate surgical intervention. Common locations of hernias in the abdomen are epigastric, umbilical, inguinal, and femoral. So the signs and symptoms that indicate a serious hernia problem are a formerly reducible mass that is no longer reducible, pain at the hernia site, tenderness when the hernia is palpated, red or bluish skin discoloration over the hernia itself. So remember, when you're assessing, you want to do a decent assessment, feel around, feel the hernia itself. Remember, blue, redness, pain, right? These are patients that potentially have a serious issue that need to have surgical intervention done. So looking at the scene size up, remember, scene is safe, gloves, that fun stuff that we talk about every single day. Number of patients, if it's several patients related to GI symptoms, suspect a release of a biological or chemical agent. Signs and symptoms of abdominal pain, nausea, vomiting, diarrhea, and other GI complaints, right? If everybody has it, there's a problem. Okay, it could have been something bad in the food, could have been a biological issue, could have been just a bug going around. A lot of times we find this in nursing homes, where one patient starts GI symptoms like a gastroenteritis or whatnot, and then it just kind of spreads throughout the entire facility. So use precautions. Form of general impression. Common signs and symptoms of irritation, inflammation of the peritoneum are local or diffuse abdominal pain or tenderness, quiet patient who is guarding the abdomen, rapid and shallow breathing, referred distant pain, anorexia, nausea, vomiting, bright red or coffee ground blood, tense or often distended abdomen, sudden constipation or bloody diarrhea, dark tarry stools, painful or frequent urination, discolored urine accompanied by a stronger odor, hypotension, tachycardia, and fever are some signs and symptoms. Patients experiencing renal and genital problems may also exhibit many of the same symptoms as a patient with other abdominal problems. So we're looking for the location of the patient, can definitely provide some clues for that. So a patient with like a urologic or renal problem may exhibit extremes of activity. So is the patient constantly changing positions to find a comfortable position, like a kidney stone dance, they call it? Is the patient sitting very still with the knees drawn to the chest? Are they in like a guarded position? In some situations, patients may also are comfortable only when lying in one specific position, like on their right side, left side, on their back, on their stomach, whatever is more comfortable for them. One aspect of the general impression is that is different for GI patients is the odor. All right, as well. So we're going to evaluate the patient's breathing, looking at ABCDEs, treat any life threats. In patients who are awake and responsive, positioning is key for them, whether it be bending of the legs. So take a pillow, put it underneath their knees, or a blanket, have them bend their legs, might reduce some of that abdominal pain. GI problems rarely affect breathing directly. Breathing problems typically stem from severe complications. So patient that have maybe gone septic. So ensure the airway is clear, assess circulation. The pulse rate and quality as well as skin condition may indicate shock. Check the pulses in both arms because a difference in pulse strength may indicate an aortic dissection. Okay, so check pulses in both arms. Expose the patient and assess for major bleeding. We're supposed to be carrying gowns in the ambulance, right? So get these shirts off patients, okay? Male or female, doesn't matter. Get their shirts off. They want to leave their bra intact, that's perfectly fine, okay? Unless we have a breathing constriction issue, then we need to take it off. Cover them up, keep their dignity, cover them up with a gown, all right? That leaves you more open space to do the assessments that you need. Nothing's going to get in the way. There's nothing wrong with taking off the patient's shirt and putting a gown on them. Okay. Evaluate for shock, may be caused by hypovolemia or sepsis. Intervention should include high flow oxygen, keeping the patient warm, and placing the patient in a position of dictated by local protocol. What is their position of comfort? What makes them feel better? We also want to make sure we're grabbing orthostatics, okay, orthostatic vital signs. So we're going to assess vital signs in two different patients' positions will help determine the extent of bleeding. I always do 3. I do lying down, sitting up, and standing. All right. Take an accurate blood pressure and heart rate, using caution to avoid loss of consciousness. When you have a patient going from a sitting to a standing position, if their blood pressures are low, they may pass out. So what I try to do is keep them standing as long as I possibly can to make sure I get that blood pressure, that I have to sit back down again. So again, you want to repeat this after a minute or 2 after they stand to see if there's any changes. With significant loss of fluid within the vascular space, there may be a 10 beat increase in heart rate and or a 10 millimeter of mercury drop in blood pressure. So look for that, document it. Those are positive orthostatic signs. So when you examine the patient with a GI problem for gross bleeding, take note of the amount of blood loss. Take note, this needs to be in your narrative and passed on to the physicians. The amount of blood in the toilet is very difficult to estimate owing to dilution. Okay, so dilution kind of makes it a little bit harder, a little bit more difficult. So practice volume estimation by pouring amounts of water that you have measured onto various surfaces, noting the size of the puddle. It usually can help you out when you're doing your assessments. We'll look at our transport decision, where we're going to go, rapid transport. ABCs, again, reassessing. Patients suspected internal bleeding. Patients with poor general impression, especially pediatric and geriatrics. Right? Where are we going to take these patients? Ensure that the ride during transport is as gentle as possible, especially if it's something with pain or if they're having maybe a potential for a AAA or an aneurysm, because any kind of bump can cause that to burst. Right? So nice, easy. Remember the OPQRSTI and investigate. So what interventions have been done? Investigate or interrogate that chief complaint. I want to know more about what's going on. So let's obtain a sample history. Nausea, vomiting, sample. Change in bowel habits and urination. If you had any excessive weight loss, belching, flatulence, any kind of pain, describe the pain to me, right? Is it sharp? Is it dull? Is it pressure? Is it radiating anywhere else? Does it come and go in waves, right? All that stuff means something, right? It's all part of our assessment. Looking at concurrent chest pain. If the chest pain is reported, use the OPQRSTI and figure out what's going on. Onset, provocation, quality, radiation, severity, time, and any kind of interventions that were done prior to. Okay. Ask female patients about their last menstrual period, right? And get more detailed. What was it like? Was it heavier than normal, lighter than normal? When was the last time you had one? All right. Right. Do not give anything by mouth. So any patient that's going into the hospital for surgery or anything else, or may have a surgical intervention, no oral fluids. Okay. They got to be NPO. Right. And then check for trauma. Perform a secondary assessment using your information gathered in the history taking portion of the patient assessment. Maybe used to focus your physical examination on the abdomen itself. Right. So pain and tenderness are most common symptoms of an acute abdomen. It may be sharply localized or diffuse and will vary in severity. So localized pain may give clues to problem organs and areas causing it. In some instances, muscles in the abdominal wall become more rigid and voluntary to prevent the abdomen from further irritation. So you'll see that guarding, which can be seen with major problems such as perforated ulcer or pancreatitis. And then you also might feel ascites, and that's that hard, rigid abdomen. So make sure you're doing a full in-depth palpation of the abdomen. Feel for the organs where they would be located. A patient with peritonitis usually has abdominal pain even when lying quietly. It still hurts. So the degree of pain and tenderness is usually related directly to the severity of the peritoneal inflammation, as you can see here in the assessment. Palpate all four quadrants. Take some time feeling it, right? Explain what you're doing to the patient. Expose and assess the abdomen, right? Auscultate. Take a listen to bowel sounds, right? Palpate, inspect. Look at it, listen to it, touch it. When you're palpating the abdomen, don't push on it really hard. Don't be rough with it. Be gentle. You're still going to put pressure on, but still be gentle, right? High respiratory rate with a normal pulse rate and blood pressure may indicate ineffective ventilation is due to pain. So let's treat the pain levels, right? Call for ALS, get a paramedic on board, right? High respiratory rate and pulse rate with signs of shock may indicate sepsis or hypovolemic shock. So use pulse oximetry and non-invasive blood pressure devices to kind of see where we're sitting. Always obtain a patient's first blood pressure manually. Using a blood pressure cuff and a stethoscope. And then we get into our reassessment. Frequent reassessment is important. We want to see if anything we've done has helped out and made any changes. Some vital signs must be released and compared with patients' baseline vitals to reassessed. If anything changes en route, manage the problem, document changes for additional treatment. Then reassess the patient and ask the following questions. Has the patient's level of consciousness changed? Has the patient become more anxious? Has the appearance of the skin changed? Has the pain gotten any worse? Has bleeding increased or decreased? Is the treatment improving the patient's condition? Has an already identified problem gotten worse or better? Is the nature of any newly identified problem? What is the nature of any newly identified issue? If the patient has GI bleeding, continue to assess for signs of shock. Reassess your vitals. Before giving additional fluid boluses, listen to the patient's lung sounds, determine whether or not whether the adult pulmonary edema is starting to develop. If the patient wants to lie on one side, try to make that possible. Let them lay on their side if it makes them feel better. Right? Get what you need to get done first and have them turn on their side. Call for paramedic backup if the patient's condition becomes unstable. Remember, medics have other methods of pain management if needed. Then provide emergency medical care as far as signs and symptoms go for the acute abdominal signal, a serious medical condition or surgical emergency. So do not delay. Before transport, do not attempt to diagnose the cause of the abdominal pain. Clear and maintain the airway. Anticipate for vomiting. Remember, you can give Zofran as an AEMT in New Hampshire, right? So we're going to give Zofran 4 milligrams IV, or we give it over ODT, oral dissolving tablet on the tongue. IV does work a lot faster and better. Administer 100% supplemental oxygen. Be prepared to assist ventilations if needed. Nothing by mouth. And all of ODT, Zofran is perfectly fine, but no food, no fluids, not by mouth. OPQRSTI, anticipating the development of hypovolemic shock, establish IV access. You want to give a 20 ml per kilo bolus of an isotonic crystalloid if the patient presents with signs of hypovolemia. Right? 20 mLs per kilo. Isotonic crystalloid would be normal saline. Administer a fluid to a keep open rate. If patient has a UTI or kidney stone or kidney function is present, administer a bolus of fluid. As far as transport goes, position of comfort, usually the legs pulled toward the abdomen is usually the best one. So pad underneath between the knees, underneath the knees. Monitor vitals, paramedic backup as needed. As far as PID goes, a pelvic inflammatory disease, acute pain and tenderness in the lower part of the abdomen may be intense and accompanied by a high fever. Pneumonia may also cause ileal and abdominal pain as well. The problem lies adjacent to the body cavity, but the inflammatory response affects the abdomen itself. Right? So treat and transport as you would any other patient with abdominal pains. Get them to the hospital, IV access, and pain management as needed. A combination of acute abdominal pain and hypovolemic shock. Consider an ectopic pregnancy in any female of childbearing age who presents with acute abdominal distress, especially in the presence of hypotension. Right? Acute signs and symptoms with shock could signify an aneurysm and require prompt transport. So again, vigorous palpation of the abdomen, you want to avoid that. if you suspect an aneurysm. Administer fluid only if the patient is hypotensive and symptomatic. Why would we only give, this is a question for you guys, why are we holding off on fluids for patients like this? What's the point behind holding off on the fluid? Anybody else? Anybody else still there? I got Justin replying. Class participation. Why are we holding off fluids?
I mean, if it's an aneurysm, I mean, we don't want to make it burst, right? I'm just
Well, you're right.
wondering.
Yeah, exactly. So the more pressure we put on the system, the higher the blood pressure, the more those arteries have to work, right? So remember, systolic blood pressure is pressure in motion, right? Under pressure. And the diastolic is your arteries at rest, correct? So if you put more pressure on the system on an already weakened lining, what's going to happen? Pop, right?
Pop goes a weasel, yeah.
Yeah, pop goes the wheel, exactly. It's no different than a fire hose, right? You can think of the same thing with a fire hose with a bubble in it. That's a weak point. The fire hose is out of service. You can't fix it. It's no different with a vessel. Weak points, they can burst, right? Sometimes they live with that for a while. Sometimes they need surgical intervention. So a hernia, we talked about hernias already, an acute kidney disease or acute kidney AKI, or a chronic kidney disease as well, can lead to life-threatening emergencies. And with hernias, transport promptly to the ED. ABCs are imperative for acute kidney disease or chronic. Be supportive. Be alert for possibility of hypotension and pulmonary edema. So reassess lung sounds. Medications regulate acidosis, electrolyte imbalance, and fluids may be required. So what medications do we have to treat electrolyte imbalance? What do we have to be able to do that? Everybody has LR. Yep. Ringers, right? Phenomenal medication. By the way, not in Massachusetts, by the way. They do not carry it for any level. It's an interfacility medication only. All right. So as far as renal dialysis goes, only definitive treatment for end-stage renal disease other than transplantation is renal dialysis, where the patient's blood is then filtered and cleansed of the toxins and normalizes the body's chemistry. There's two types. There's hemodialysis or peritoneal dialysis. Peritoneal dialysis is when they stick a tube in the peritoneal cavity, or they can get hemodialysis through fistulas. Adverse or complications or adverse effects of dialysis would be hypotension. If they take too much fluid off too fast, it can cause severe hypotension. Muscle cramps, nausea, vomiting, hemorrhage from the access site, infection as well. Altermentation, loss of consciousness, air embolus, electrolyte imbalance, and myocardial ischemia. So a sudden drop in blood pressure is not uncommon during immediate after dialysis, but you'll look for electrolyte imbalances as well, which may develop. So cardiac arrhythmias, if you're called 911 to a dialysis center, or they may just give up and not want to go anymore as well. Shock secondary to bleeding is also possible. So if a patient misses the dialysis treatment, weakness, pulmonary edema, and excess of electrolytes may also start to develop, causing significant arrhythmias, even cardiac arrest. So if you're called to a patient with dialysis, start the ABCDEs, high flow oxygen, manage any major bleeding from a site. Please do not put tourniquets over fistulas, right? You will damage them, and it's a surgical intervention to fix it. Apply pressure with your hand over the site. A lot of times in dialysis centers, they have clamps already there, right? They have to stay on for 20 to 30 minutes prior to taking your patient or coming off to make sure it clots appropriately as well. Disequilibrium syndrome is dialysis rapidly lowers the concentration of urea in the blood, whereas the concentration of solutes in the cerebrospinal fluid remains high. This will cause the disequilibrium syndrome. And the last, air embolus. So if any of the fittings and connections in the dialysis system are loose, air may enter the system, producing an air embolus in the patient. Symptoms include sudden dyspnea, hypotension, and cyanosis. If you suspect an air embolus, disconnect the patient from the dialysis machine, lie the patient in a flat supine position, and transport immediately to the hospital. All right, why don't we take 10 while I switch over.
This conference will now be recorded.
All right, so let's talk about the endocrine and hematologic emergencies, chapter 21. All right, so the endocrine system influences every cell, organ, body function, right? Endocrine disorders can have as many signs and symptoms, and hematologic emergencies are rare in most EMS systems. However, difficult to assess and treat in the pre-hospital setting. So let's talk about AEMT. So the network of glands that produce and secrete hormones, major components, hypothalamus, pineal gland, pituitary gland, thyroid, thalamus, parathyroid, adrenal, pancreas, gonads, all these different glands that all play a huge part in a secretion of hormones. Hormones are chemical substances produced by glands, which we already obviously know looking at this. And the chemical they have a special regulatory effect on other organs and tissues. So endocrine glands secrete or release chemicals such as hormones inside the body, right? So the main function of the endocrine system and its hormone messengers is to maintain homeostasis and promote permanent structural change. The pituitary gland is located at the base of the brain, divided into anterior and posterior regions. 6 of its hormones stimulate other endocrine glands. They call tropic hormones, sorry. So ACTH being one of them. Follicle stimulating hormones, growth hormones, luteinizing hormones, prolactin, and thyroid stimulating hormones as well, which is TSH. So a lot of times when you go to a hospital and you have potential for certain lab work, I'm having a moment right now for why they would test it. I can't think of it. But they can do prolactin checks and then what they call a TSH check as well. Those are specific lab orders that can be ordered on top of the normal to kind of check and see where your hormones lie as well. I'm just having a moment where they would test TSH for. I don't know why I can't think of it. I'm sure it'll come back to me in a moment. So ACTH targets the adrenal cortex and causes it to secrete cortisol. There are some issues though as well with your thyroid issues and things like that, where you have an overproduction of cortisol, right? So you've heard of Cushing's triad, right? We all know what Cushing's triad is for. Right? Yes, okay. So that's used for intracranial pressure. Cushing's syndrome is different than Cushing's triad. Cushing's syndrome is an increased production of cortisol, which we just talked about here, right? So the production of cortisol, and that's what causes that swollen, what they call a moon face. So you'll see that as well. So the thyroid gland then secretes hormones in response to stimulation of the thyroid gland by the anterior pituitary gland, which secretes thyroxine or T4, which stimulates energy production when the body's metabolic rate decreases, which stimulates energy production in the cell. At this time, then it starts to secrete calcitonin, which helps maintain normal calcium levels within the blood. So they can do calcium checks as well. That's also part of your complete metabolic panel. This travels to the bones, where it stimulates the bone building cells to absorb excess calcium. It also stimulates the kidneys to absorb and excrete excess calcium as well. So as you can see, the thyroid gland is actually very important. And we do what they call a TSH check to check your levels of on your thyroid gland as well. The pancreas is considered both an endocrine gland and an exocrine gland. So the exocrine component secretes digestive enzymes into the duodenum via the pancreatic duct. The endocrine component secretes hormones from cell groups called the islets of Langerhans, right? And this secretes the polypeptide hormones, glucagon, insulin, and somatostatin as well. One second here. All right. So the role of the glucose and insulin, when it works. Glucose is a major source of energy for the body, sugar, right? We have to have sugar in order for our body to survive. So without glucose or with an externally low glucose level, extremely low glucose level, the brain cells rapidly suffer permanent damage. Remember, blood, oxygen, sugar. So in all areas of the body except the brain, insulin is needed to allow glucose to enter individual cells to fuel their functioning. So insulin is responsible for the removal of glucose from the blood for storage of glycogen, fats, and proteins. All right, as you can see in the image here on the screen. So when blood glucose levels are elevated, the islets of Langerhans secrete insulin. Right, we eat food, glucose goes up, islets of Langerhans then secretes insulin out. Insulin then increases cell membrane permeability and mediates the transport for glucose across the cell membrane into the cells. Cells then use glucose, right, to produce energy through processes that include glycolysis. So insulin also stimulates the liver to store excess glucose and the skeletal muscles to store glycogen for later use by the body. So when the blood glucose levels decrease, alpha cells of the islets of Langerhans release the hormone glucagon, and glucagon then raises the blood glucose levels and brings the body's energy back to normal by stimulating the liver to convert stored glycogen back into glucose through the process called glycogenolysis. So the glucose is then secreted into the bloodstream where cells that can use it later for energy. If stored glycogen levels are depleted, the cells begin to metabolize fats, proteins, and other non-carbonate sources, producing new glucose called glucogenesis. Right? So what is really going on here then? Taking all of what I just talked about. Blood sugars go up, what gets released?
Insulin.
Insulin, correct, right? Which then decreases your blood sugar to hopefully stable it out. If your blood sugar goes too low, what gets released?
Glucose.
Right, glucose, right? Or glucagon, which rises the blood glucose level, bringing the body's energy back to normal, right? So we talk about glycogenolysis, right? Genolysis. I don't keep saying losis. My goodness, right? So we talk about that, right? The process where we start converting the stimulating the liver to convert stored glycogen back to glucose through that process, right? If you run out, if the stored levels are depleted, then we start metabolizing fats and proteins, right? Called glucogenesis. Very similar to what? Ketosis. that very similar to ketosis? And where would you find a patient in ketosis? Yeah, DKA. Or the keto diet, when they put their body into ketosis on purpose, right? New trends, new diet trends, exactly. All right. So a patient who has a light meal, right? They go out and run a marathon, right? Burning off sugar, burning off energy. Our body runs out of stores. Now we start metabolizing fats and proteins, right? Patient doesn't feel well. They're not a diabetic. They don't feel well at the end of a run. What happens? What do you do? How do you assess your patient? They're cramping up, right? So we think cramping, muscle cramps. We think of low potassium, right? Have a banana, feel better. Check a blood sugar, right? Now we're burning off all these different stores, right? Glycogen levels are depleted. Now they got to burn something else. When they run out, they become hypoglycemic, right? Now our electrolytes are off. Electrolytes are off. What happens? We start getting cramps. Okay. So there's a process that effect of what's happening based upon what they've done, right? So we want to make sure we look into that. Check it. Check a blood sugar. So the pathophysiology of the endocrine system, where endocrine disorders can be caused by either hypersecretion or insufficient secretion of a gland. Hypersecretion presents as an overactivity of the target organ regulated by that gland. So insufficient secretion results in underactivity of the organ controlled by them. Hyperthyroidism and hypothyroidism are two serious illnesses of the endocrine system. Hyperthyroid increases metabolism. Hypothyroid decreases metabolism. So a lot of times patients that are very overweight, right, have a TSH check, and if it's low, they could be put on medications to help regulate their thyroid. And then they end up losing weight because now their body is increasing metabolism. So most of the endocrine emergencies related to a diabetic emergency is secondary to abnormal insulin secretion. Hypothyroid and hyperthyroidism, we just talked about those. One increases. Hyperthyroid has an increased metabolism rate. Over hypothyroidism, decreases metabolism as well. All right, so diabetes mellitus is a metabolic disorder now thought to be associated with a group of complex diseases with many causes, like gestational diabetes, diabetes mellitus, hypo and hyperglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic non-ketonic syndrome, right? Or they call HHNS or HHNC instead of syndrome of coma. The end result is hyperglycemia, okay? So high blood sugar. These are characterized by the 3 P's, okay? Polyphagia, which is an increased appetite. Polydipsia, which is a substantial thirst caused by dehydration, right? Brought by an increase in diuresis. And polyuria, the passage of large quantities of urine. In diabetes, excess glucose is excreted in the urine and attracts water, resulting in excessive diuresis. So patients that have diabetes mellitus will have the increased appetite, increased thirst, and increased urine output. The body is also unable to sufficiently metabolize glucose. So mellitus refers to the presence of glucose in the urine, responsible for life-altering complications, decreased kidney function, increased risk of coronary artery disease, microscopic deterioration of vessel walls, resulting in swelling of the basement membrane cells, cerebrovascular disease, stroke, hypertension, and peripheral artery disease, damaged vessels of the eyes causing swelling, wall weakness, and obstruction, neuropathy, which affects peripheral nerves, causing diminished sensation, and any pre-existing condition be more difficult to manage as well. As you can see, looking at the poor circulation of the legs. Wounds on the legs will take longer to heal as well, just due to poor circulation and that neuropathy. So both chronic and acute complications are associated with diabetes mellitus. If left untreated, diabetes mellitus and organ system dysfunction will result in organ system dysfunction, a wasting of the body tissue, and death. There are two forms of mellitus that exist. One is type 1, which is formerly known as the juvenile onset, and type 2, which is formerly known as the adult onset diabetes. Prediabetes is now recognized as a warning sign that may precede the development of type 2 diabetes. Right. So with type 1, historically referred to as insulin-dependent diabetes mellitus, or IDDM, or juvenile onset, because it generally affects children, has a hereditary predisposition where the body may develop autoantibodies that incorrectly identify the body's own tissue or substance as foreign invaders. So the rate of beta cell destruction is now variable. Latent autoimmune diabetes in adults is a variant of type 1 diabetes that occurs in adults older than 30 years old. So in addition to the daily insulin injections, strict dietary control must be observed with this, right? So ask the patient those questions. Do you take insulin? Do you regulate your sugars through diet as well? What have you been eating? Have you had any changes in your diets? Increased activity and alcohol consumption can also result in low blood glucose levels with this, right? So again, questioning is going to be key to these patients to find out what's been going on with them, right? Some patients may actually have insulin pumps, which provide improved control of blood glucose levels and better quality of life for many patients. Type 2 diabetes is the most common. The body becomes resistant to the insulin produced, typically develops when a person is middle-aged, although the disease is becoming more common in younger people. When glucagon levels remain high, excess amounts of glucose are produced, resulting in high blood glucose levels. So the development of type 2 diabetes has been associated with obesity and physical inactivity, two characteristics becoming more common in today's populations. So symptoms left untreated would be fatigue, nausea, frequent urination and thirst, unexplained weight loss, blurred vision, frequent infection and slow healing of wounds, being cranky, confused, and shaky, unresponsiveness, and seizures. So we have a patient that has elevated blood glucose. How are we going to treat that in the field? And no, we don't have insulin available to us. Fluids, saline. Let's break down the fluid. Let's break down the blood. Let's dilute it a little bit more and hopefully reduce the sugar content. So patients that take metformin usually take it about a half an hour prior to eating food, which causes a decrease in glucose production. So when you eat, in hopes that your blood sugar won't go through the roof. But again, though, weight loss is an important factor as well in helping control that type 2 diabetes. So not dieting, but portion control and eating the right foods will help. So prediabetes is identified in people who have certain risk factors associated with type 2 diabetes. Blood glucose levels are hemoglobin A1C or HA1C levels are above normal levels, but not high enough to be diagnosed as diabetes. So the goal for diabetic patient or an A1C level is of 7% or less. Right? The goals for diabetics are usually right around 5. Anything above 7, we start getting worried. So risk factors include older than 45, being overweight, family history, being African American, Hispanic, Latino, American Indian, Pacific Islander, and some Asian American racial or ethnic backgrounds, gastrointestinal, gestational diabetes, or having given birth to a baby who weighed more than 9 pounds or 4 kilos, being physically active fewer than 3 times per week, Losing 5 to 7% of the patient's body weight and getting at least 150 minutes of physical activity per week can prevent or delay the onset of type 2 diabetes. So losing 7% of your body weight, right? And then also exercising this 150 minutes per week will help. Gestational diabetes or glucose intolerance that can occur during pregnancy. Women who experience gestational diabetes during pregnancy have a 40 to 60% increased risk of developing type 2 diabetes within 1 decade. So for most women, gestational diabetes will resolve before delivery. What's going on is blood glucose crosses the placental barrier, where we have high levels of glucose that enter the fetus and increase the fetal production of insulin. Extra glucose then converted to fat by the fetus. Women often deliver large babies or may require a cesarean section, C-section. The risk of birth defects are low, and management includes diet modifications, exercise, and blood glucose testing. Hypoglycemia is often a result of having taken too much insulin or too little food or both. This results in a hypoglycemic crisis, or what they call insulin shock. So counterregulation is the body's natural defense ability to maintain blood glucose at an appropriate level. So the first line of defense is reduce insulin production and increase glucagon production. And the second line of defense is secretion of catecholamines by the adrenal gland. So with this, stimulation of the autonomic nervous system generates signals that allow production of counter-regulatory hormones to increase. The liver then uses these products to make new glucose for the body in a process of glycogenesis. Refer to that, gluconeogenesis. In patients with type 1 diabetes, the islets of Langerhans do not make insulin. In patients with type 2 diabetes, the pancreas can generate insulin, so these patients can produce insulin production within their own bodies. So the lack of glucagon response makes the body more dependent on epinephrine to overcome the effects of hypoglycemia. Patients will experience trembling, a rapid heart rate, rapid shallow respiration, sweating, and a feeling of hunger. Common signs would include blood glucose levels less than 70, hunger, agitation, irritability, or combative behavior that cannot be explained, altered mentation, confusion, nausea, weakness, dizziness, fainting, tachycardia, and poor cardiac output, cool, clammy skin as well. So some common problems experienced by the patient with either type 1 or type 2 diabetes. Patients also appear to be intoxicated because of the slurred speech and lack of coordination, and also may be paranoid, hostile, and aggressive. This is easily treated, so do not discount the possibility of hypoglycemia in a comatose patient just because the patient is not known to have diabetes. Check a blood sugar. Do not let a known diagnosis of diabetes prevent you from considering other causes of coma. Right? Don't get the tunnel vision. Look at your patient, look at the signs and symptoms, look at differential diagnosis, be a clinician, and treat your patient. Hyperglycemia and diabetic ketoacidosis occurs when blood glucose levels remain elevated and corrective mechanisms have failed. This can be caused by excessive food intake, insufficient insulin dosaging, infection or illness, injury, surgery, and emotional stress. So we have a diabetic coma, which is a hyperglycemic crisis, is a state of unresponsiveness resulting from several problems. Some common early signs include frequent and excessive thirst, accompanied by frequent and excessive urination. The onset may be rapid or gradual, and repeated episodes of hyperglycemia will cause several psychological changes that have detrimental long-term effects. When serum glucose levels rise above a tolerable level, diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic non-ketonic syndrome, HHNS, will occur. Some common causes of DKA include infection, injury, alcohol use, emotional distress, and illnesses such as stroke or myocardial infarction. This is why we check blood sugar as a patient's having a heart attack. So the loss of water in large amounts of causes classic symptoms of uncontrolled diabetes. This is the 3 Ps: polyuria, polydipsia, and polyphagia.
Oh, hurry up and pull up, pull up, pull up.
So, excuse me, hyperglycemia and diabetic ketoacidosis. So when fat is used as an immediate energy source, ketones and fatty acids are formed as waste products and are difficult for the body to excrete. So large quantities of ketone bodies in the bloodstream causes a decrease in the blood's pH and a result in metabolic acidosis. Ketones are responsible for the sweet, fruity breath odor associated with DKA. So proper fluid rehydration and insulin are not given, ketoacidosis will progress to unresponsiveness, diabetic coma, and even eventually death. So DKA patients are seldom deeply comatose. We want to make sure we correct that action. The signs and symptoms would be blurred vision, polyuria, polydipsia, polyphagia, orthostatic syncope, frequent infections, and skin ulcerations. Manifestations would be polyuria, polydipsia, polyphagia, nausea, vomiting, tachycardia, deep rapid respirations or Kussmaul respirations, warm dry skin with dry mucous membranes, fruity odor of ketones on the breath, abdominal pain. Sometimes there might be a fever as well. Respiratory rate is usually elevated, and the tidal volume is increased because of the ketonemia, acidosis, and to relieve excess burden of carbon dioxide by the body. This results in hypocapnia, so the low carbon dioxide. DKA results in both Kussmaul respirations and metabolic acidosis. And in patients with type 2 diabetes, DKA is rare because insulin is still present. So with increased duration of type 2 diabetes, a loss of pancreatic insulin production may occur. So in this table here, this compares hypo versus hyperglycemia. So HHNS, or formerly known as hyperosmotic non-ketonic coma, or HONC. I've heard of HHNC, HHNS. I've heard of a bunch of different ones that are out there. Either way, it's hyperosmolar, hyperglycemic non-ketonic syndrome. Occurs principally in patients with type 2 diabetes, characterized by hyperglycemia, hyperosmolarity, and absence of substantial ketosis. Hyperosmolarity describes highly concentrated blood as a result of relative dehydration. So signs and symptoms would be elevated blood sugar, hyperglycemia, altered mental status, drowsiness, lethargy, severe dehydration, thirst, and darkened urine, visual or sensory deficits, seizures, partial paralysis, and muscle weakness. So the clinical features of HHNS and DKA tend to overlap and are often observed simultaneously. Often develops in patients with diabetes who have had secondary illness that results in reduced fluid intake. Patients do not experience ketoacidosis with this. So as far as the scene size up, again, it's the same thing. Scene safety, hazards, look for insulin syringes on the nightstand, be observant, situational awareness. Glass of orange juice are important clues that may also help decide the problem as well. So look around, look for the half-eaten candy bar. insulin syringes, things like that on the floor. Look in the refrigerator where the insulin is stored. Question bystanders. Determine whether or not the patient, that this is the only patient or whether trauma was involved. Right? Look for that motor vehicle accident, low impact with an unconscious patient. Why are they unconscious? This doesn't make any sense to me. It doesn't seem right. Form a general impression and do a rapid scan. In patients with altered mental status, expect low blood glucose levels. Anybody with an altered mental status gets a blood sugar. Anybody that's ETOH gets a blood sugar. Anybody that's hypothermic gets a blood sugar, right? So check for those. Cervical immobilization when indicated. Please do not do cervical spine motion restriction if they don't need it. Assess the patient's breathing, airway as well. If the hyperglycemic patient may have rapid deep respirations or Kussmaul's or a sweet fruity breath odor. If hypoglycemic patient will have a normal or shallow rapid respiration, right? If they have a low blood sugar, let's treat it. Get an IV in place and give D10. Moist pale skin usually indicates hypoglycemia versus dry warm skin, which indicates hyperglycemia. Hypoglycemic crisis will have a rapid weak pulse. So as far as history taking, investigate the chief complaint. Look for physical signs as well. Get your sample history and check for emergency identification devices like bracelets, anklets, things like that. The medical ID stuff in someone's phone if they're unresponsive. Do your secondary assessment. Remember, unresponsive patients get a full body exam, right? With unresponsive patients or a patient with altered mental status, look for problems or injuries that are not obvious, right? Patient may have sustained trauma. We're not sure. So do an assessment. Don't just walk in and assume, oh, it's a diabetic because they have a history of it, right? Do a full assessment. They could have fallen, hit the back of their head, causing altered mental status. Could be traumatic in nature, right? It could be a stroke. Get a GCS score to track the patient's neurological status, vital signs, glucometer readings, right? Look for the normal range, 70 to 120. Less than 70. Remember, blood glucose levels in neonates should be higher than 70 milligrams per deciliter, okay, for neonatal. Get a reassessment, reassess the diabetic patient frequently and assess changes, right? Monitor the patient carefully for potential vomiting. If they're nauseous, give them medication to prevent vomiting from happening. Vomiting can cause significant dehydration and as well. So base administration of glucose and serial readings. Okay, so frequent readings of blood glucose checks, and keep hospital personnel informed. As far as IV placement, patient has altered mental status, establish an IV line. Transport unresponsive patients supine in recovery position to protect their airway. Keep their mouth and pharynx suction free of secretions, vomitus, and blood as well. So take a look at your airway ABCs to make sure everything is functioning appropriately. Administer oral glucose. Everybody in the room feel good with oral glucose? Or do you mean to go over it in detail?
I think we're good.
I like it. Good, good. All right, cool. Please do not give a sugar-free drink that are sweetened with saccharin at all. Okay, they need true sugar, right? Remember that in New Hampshire, you have to use New Hampshire pure maple syrup, not Vermont or Maine, right? It actually strictly does state New Hampshire maple syrup in it. Vermont states Vermont maple syrup in it, not New Hampshire's. Here comes the battle. All right. If the patient is unresponsive or if they have an altered mental status, unable to maintain their own airway or swallow, we want to make sure we give intravenous dextrose. There's different methods you can utilize. 12.5 to 25 grams of D50 for adults, or we can do D10. I'm pretty sure, 99% sure, you guys are going to be tested on D50 administration, right? Which we already covered a little bit. We'll do more on practical days as well, right? But D10 is 250 mLs of fluid with 25 grams of sugar in it. They also come in 500 bags as well and 1,000 bags, right? So look at your concentration. D50 has 25 grams of sugar in 50 mLs. To put that into perspective, a small can of Red Bull has 50 mLs of fluid in it and has like 26 or 27 grams of sugar in it. So we're giving D50s to diabetics that are unconscious. As far as administering glucagon, glucagon, just so you guys know, is very expensive. I'm not saying don't use it. They're about $300 a vial. Glucagon is supplied in 1 milligram ampules. Right now, looking at the kit that's here, okay, they have to have. This is supplied in a powder form, and either they'll have the kit that has a syringe that has fluid in that you inject into the vial, then redraw it back up. Right. The dose for an adult is 1 milligram intramuscular and may be repeated 7 to 10 times. We do not carry that much, okay, at $300 a vial that we rarely ever use, right? The dose for kids, pediatric is 0.5 milligrams for children who weigh less than 20 kilograms. The dosage is the same for adults as for children who weigh more than 20 kilos, right? This is usually given intramuscular, usually in the right or left deltoid is the best spot for it. Some kits are not set up this way. They have a syringe. They have a separate vial of sterile water. Please do not use sodium chloride for a mix. It has to be a sterile water system. Injected into the vial, shaken up, then redrawn back out for the IM injection. When you're drawing up, you can use an 18 gauge needle. It's perfectly fine. But when you're administering it to a patient, please don't go anything bigger than a 22 or 23. Right? 18 gauges are just cruel. Very large needles sticking into somebody's arm, causing pain. You can do a lot through a 22 gauge catheter or needle that hooks on the end of the syringe. As far as management of hyperglycemic and DKA patients, if it's more than 250, the physician will probably order a treatment for DKA. All we're going to do in the field, honestly, is be alert for vomiting. If they're nauseous, give them some Zofran to protect them from vomiting, protect their airway. We need to correct the electrolyte imbalance that's there. So we're going to get a crystalloid solution for signs of dehydration at 20 mLs per kilo and treat the patient symptomatically. For management of the HHNS, we're going to follow the pathway for dehydration, ultimental status, and complete advanced airway management as early as possible. Right? If they're unconscious and not breathing, we can put in a King Airway, an SGA. If not, contact the paramedics. We can do intubation. We want to get large bore IVs should be gained. So large bore is 18 gauge. If the patient has a history of heart failure and or renal insufficiency, be very careful with the fluid administration. Fluid deficits in patients with HHNS may amount up to 10 liters or more. That's a lot of fluid. Okay. All right. Any questions on the diabetic stuff? Doing okay with it so far? Everything good? Perfect. No questions. All right. Feel free to partake if you guys have any questions. All right. So hematologic emergencies are the study of blood, hematology, assesses ways in which constitutes parts of the blood are involved in health and disease. Our components, all right, which would be done on a what they call a CBC or a complete blood count, would be red blood cells, white blood cells, platelets, proteins, and the hematopoietic system, or we talk about hematocrit and hemoglobin. So a lot of times we look at a red or white and an H and H. Hematologic disorders refers to any disorder of the blood, like hemolytic disorders refer to a disease process that causes the breakdown of red blood cells, and hemostatic disorders refer to bleeding and clotting abnormalities where they lack certain factors. Right? So with that being said, blood and plasma, the functions of blood transports, obviously we know about what blood does, right? It transports red blood cells with oxygen, hemoglobin attached to perfuse the body. It also has white blood cells to help fight off infection. So when would you find a patient that has a decreased white count?
Cancer patient.
Yeah, patients that have cancer, right, that have been ongoing chemo, which would make them immunocompromised, right, to protect them and yourself as well, right? And when would we find a patient with a elevated white count? Elevated white count.
Septic patient.
Yeah, septic, infections, right? Any kind of an infection. So this transports oxygen to the lung and the tissues and carbon dioxide from the tissues to the lungs. Nutrients, carries waste products, transports hormones, and carries defensive cells and antibodies. So if we have a deviation from that, right, then we have an imbalance, right? We could have a low blood and they might need a blood transfusion or blood infusion. Other components would be plasma, which is a straw-colored fluid that is 92% water and 6 to 7% protein, right? There are ways and abilities for patients to receive plasma, as well as PRBCs or packed red blood cells or blood, whole blood. Remains consistent in the variety of other elements, including electrolytes, clotting factors, and glucose, and accounts to 55% of the total blood volume. All formed element components, red, white platelets, are transported through the body in plasma. Red blood cells, erythrocytes, or 99% are formed elements in the blood. Within the RBCs, iron-rich hemoglobin is responsible for carrying out oxygen, right, within the hemoglobin. With that being said, production occurs within the stem cells. Oxygen is then attached to hemoglobin, which gives blood its characteristic red color. White blood cells, or leukocytes, right, are providing the body with immunity, derived from stem cells. There are several types of white blood cells exist. We have platelets, which are responsible for clot formation. Then we have hemostasis, which is a highly complex process that allows the body to stop bleeding through vascular spasm, coagulation, and platelet plugging. When injury is detected, thrombin converts fibrinogen into fibrin. This is where the clotting process starts to begin. Any process that interferes with the activation of this continuation of the clotting cascade, or hemostasis, is called a coagulopathy. When we apply a bandage to a patient, that mesh-looking bandage actually helps promote clotting when it's over the patient's skin. So it helps trap the platelets and the fibrin and things like that to help form that clot. This is actually designed for. So blood-forming organs and red blood cell production with bone marrow. So bone marrow is the primary site for blood cell production, which is found in most long bones, pelvis, skull, and vertebrae. The liver produces clotting factors found in the blood, also helps filter and remove toxins, essential for metabolism and homeostasis, and is highly vascular, where the spleen is very vascular, where it filters and breaks down red blood cells, helps produce white blood cells, and an important role in providing homeostasis and infection control. So as you can see, as far as hematology goes, it's very important to make sure these patients have appropriate cells within the body. If a patient has a significant bleed or they're bleeding out, we're losing those blood cells that help fight the infection, that help clotting, right? They're leaking out all over. We can't keep up, right? This is where we need to administer fluid. What they really need is whole blood administered back to the patient with an infusion. So blood classifications are different types of classes. From ABO systems, use RBC classifications as O, A, B, and AB. It indicates which antigens are found in the plasma membrane. So if you look at table 21-4 in your books, you'll be able to see that. Blood contains a secondary antigen known as an Rh antigen as well. With that, transfusion reactions also can be possible. Some patients may have previously received blood transfusion from somewhere else. It's important to determine a patient's blood type and the type of blood received. So for us up here where we work, for a lot of us, we draw labs in the back of the ambulance for the hospital, right? So depending on what hospital, depends on what colored tube they use, but the local hospitals use a pink tube, which is where you draw a type and cross, and that type and cross does a cross type of the blood to see what type of blood you have with the Rh antigen, which then in turn will allow the hospital to go to the blood bank and get the appropriate blood. So if we draw stuff early for trauma patients, they can get this stuff in, get the panels back fast enough to start treatment. So blood reactions occur rapidly and can cause severe circulatory collapse and even death. So when a patient receives blood at transfusion, monitor the patient closely for the first 30 to 60 minutes, because they may have a change. So sickle cell disease, most commonly inherited blood disorder, it primarily affects African Americans, Puerto Ricans, and the European populations. The average life expectancy is 42 years for men with sickle cell anemia and 48 for women. Sickle cell disease starts with a genetic defect of the adult type hemoglobin, or HbA, right? Defective red blood cells have an oblong shape, which I'll show you guys in the next slide, normal versus oblong, which give them that sickle look, right? So sickle cells have a much shorter lifespan than normal erythrocytes, predisposing the patient to anemia. So they become very anemic. What reading would you get as a false reading for patients that are anemic?
SPO2.
SpO2 is correct, yes. All right, so SpO2 will give you false readings if they have carbon monoxide poisoning or if the patient's anemic. So as you look here, the picture out here on the left, that's a normal blood cell, right? As you can see on the one on the right, the pink cells that are here, those are sickle cells, all right? So that's the difference between the two if you look under a microscope. So sickle cell disease is an acute crisis where patients have a substantial pain resulting from congested vessels, where the patient with chronic sickle cell attacks are susceptible to severe life-threatening complications. They may have signs
Can I
of
ask a
mild.
quick question? Oh,
Yeah,
sorry. What does the SP and SPO2 stand for?
trying to get the correct terminology for it. Stand by a minute.
Thank you.
It's a partial pressure of oxygen that's in there. I'm drawing a blank on the S. I don't know why. I guess it's just getting late. But it's a partial pressure of oxygen. It can also be measured through arterial blood gases as well, like a PaO2, SpO2.
Is it saturation pressure?
I'm not sure if it's saturation of partial pressure of the oxygen. We're looking at that saturation level versus a blood gas, which we would look at partial pressure, or what they call a PaO2 reading. So partial arterial pressure readings. Does that make sense at all? But it is looking at the saturations. I just can't remember off the top of my head what the SP stands for, but I think it might be saturation pressure. You're right.
Yeah, I'm like, I don't know what that means. So that's all good. All right, thank you.
That's a fair question. All right. Some other potential complications of sickle cell disease are CVA, gallstones, jaundice, leg ulcers, opiate tolerance, osteomyelitis, or septic arthritis, chronic pain, chronic renal failure. You can see all the ones that are listed here quite a bit. So patients that are anemic or hemoglobin or red blood cell levels that are lower than normal are associated with some type of underlying disease process. like iron deficiency anemia, which is the most common type. So in children, the most often related to premature birth or low birth weight, may sometimes be caused by inherited hemolytic disorder as well. Patients will report feeling worn down or having no energy. Patients that become anemic. Some may have a, yes, sorry.
Peripheral oxygen saturation.
Peripheral oxygen saturation is SpO2.
Yep.
There you go. Thanks.
Welcome.
Thanks, Matt.
Welcome.
All right, trying to figure out where I was. So other common conditions include leukopenia and thrombocytopenia as well. With that, other clotting disorders or thrombosis is a development of a blood clot occurring in arterial or venous blood vessels. Symptoms are related to the part of the vascular system in which the clot occurs. So thrombophilia is a tendency to develop blood clots, which is a very common medical problem. Thrombosis may manifest as a formation of a blood clot in a blood vessel or in one of the chambers of the heart, where you'll have a pulmonary emboli secondary to deep vein thrombosis, a leading cause of death in hospitalized patients. Many patients receive anticoagulant medications because of this. Right? So we have different clotting disorders or overclotting. So risk factors include recent surgeries, impaired mobility, heart failure, cancer, respiratory failure, infectious disease, age older than 40 years, overweight, and obesity. Other risk factors would be smoking, oral contraceptive use, recent trauma, or recent long distance travel, multi-hour car or plane rides. That's why it's so important to get out and stretch if you're on long car rides, to keep the blood flow moving. So you'll develop what they call a deep vein thrombosis that can cause a thrombus to go through the system, causing a pulmonary embolus. Hemophilia is a genetic disorder, bleeding disorder in which clotting does not occur, like von Willebrand's disease insufficiently, where the body is unable to develop spontaneous clots as normal. So classified into two primary types, we have hemophilia A and hemophilia B. Hemophilia A is the most common type where you have low levels of factor VIII, where hemophilia B is the second most common type, which you have a deficiency of factor IX. So signs and symptoms of A and B are really the same and may or may not be life-threatening. Spontaneous intracranial bleeding is very common and a frequent cause of death. Right? So disseminated intravascular coagulation, or DIC, may result from a number of life-threatening conditions. This progresses in two different stages, where first, where free thrombin and fibrin deposits in the blood increase and platelets begin to aggregate. The second is uncontrolled hemorrhage resulting from severe reduction of clotting factors. When would you see a patient with free thrombin and fibrin deposits in the blood increasing and platelets beginning to aggregate? What could cause DIC?
Trauma patient.
Trauma, what else? That would be the uncontrolled hemorrhage.
Cancer.
Yeah, how about an infection as well? Pneumonia could turn into DIC. Pneumonia. Pneumonia turning sepsis, turning into MODS, turning into DIC, which then would lead to amputation of a limb. All because of pneumonia, all because of a paper cut that causes an infection and widespread vasodilation, causing multiple organ dysfunction syndrome, MODS, which then turns into disseminated intravascular coagulation. This is why it's so important to pick up on sepsis so quickly. Mortality rate for patients is quite high. The primary cause of death related to uncontrolled bleeding is hypotension and shock. So we want to identify the signs and symptoms commonly associated with DIC or progression towards coagulopathy. So as far as scene size up goes, again, it's the same thing as we talked about before. Standard precautions, evaluate mechanism of injury, number of patients. Is a patient experiencing a vaso-occlusive crisis that would benefit from administration of analgesics, right? Analgesics being medications for pain. So we do a primary survey, ABCs, full body scan, breathing assessment, pulse oximetry. Less than 94 receive high flow oxygen. Be aware that even minor trauma during these procedures can result in bleeding into the airway and increased risk of airway compromise. Check your circulatory status and increase heart rate and represent a compensatory mechanism, right? So look for that tachycardia. If a patient is suspected hemophilia, be alert for signs of acute blood loss. Rapid transportation will depend on the severity of the patient's condition and wishes, right? Patients with hemophilia will exhibit or may exhibit signs of hypoxia or shock, so fluid resuscitation may be necessary for patients, but take care not to wash out clots that are currently forming. History taking, again, sample OPQR-STI, level of consciousness, ascertain whether this pain is isolated or felt throughout the entire body, right? So as you were having a sickle cell crisis or not. Have you ever had a sickle cell disease crisis before? If so, when was the last time you had it, and how did your last crisis resolve? Have you had any illness, unusual amount of activity, or stress lately? All important questions. Perform a secondary assessment, which may be performed on scene, en route to an emergency department, or not at all. You don't have time to get to it. Systematically examine the patient, focusing on major joints at which cells congregate, and obtain your patient's baseline vitals. Joint pain is very common with sickle cell anemia. And then reassess your patient. Other medical care should include oxygen fluids, initiate IV fluid replacement as needed. Transport, pain management is often necessary for sickle cell crisis. Usually more of narcotic use like Dilaudid, things like that, some of the higher hitters. Place the patient in a position of comfort and psychological support for transport. So management of care for sickle cell disease might include analgesics for pain, antibiotics to prevent infection, and blood transfusions as required. In cases of anemia, check and monitor the airway for patients breathing. For patients reporting chest pain, call early for paramedic backup. Identify DIC as established treatment early, and be optimistic, but be honest with the patients and the family. All right, with that being said, turn off the recording here.